Thank you. So good noon, everyone. So a gastroenterologist is standing between you and your lunch. So, but I would be very brief. I won't take your much time. So, first of all, it's an absolute pleasure to be here, to be a part of this academic fiesta by AFPA. And the topic given to me is the recent advances in gastroenterology. So we all know regarding the advancement, you all must be aware regarding these devices which we were using a decade back, which was only, we could only able to call a person by these devices. But nowadays we have these devices which can do almost everything which a laptop can do. So similar way you can see in this picture, it was endoscopy a decade back, a few decades back I would say, where a sword like endoscope is getting inserted into a food pipe. So how painful it is. But nowadays you can see such a delicate endoscope which is being used in clinical practice. So the term recent advances comes, the people are worried, oh, I will be having a guidelines. But I'll not go in detail regarding the guideline which has changed over the decade, but I will brief you how a newer instrument or the newer advances that has been taken place in the field of gastroenterology. So what we know so far, when you think about a gastroenterologist, obviously it is the burning, bloating, flatulence, or a constipation or a diarrhea. We all know regarding the endoscopy and the colonoscopy. We all know regarding the ERCPs for the stone removal. So what else? What is new? So this is a list actually. So I am not telling that this test is being done in the Western world, in USA or UK, but I will point that these tests are actually available but highly underutilized by us because this. So I will only explain what actually we are doing in our clinical practice, and I'll not add those tests which are doing in a Western world. So I'll start with each topic. The first is the GERD. See, this is one of the commonest complaint which a physician encounter in the clinic. I think it is the second common after the viral illness, I would say. So GERD, the patient comes with the chest pain, the heartburn, the vomiting, the regurgitation, and what we do, we give the PPI like rabeprazole and pantoprazole, and it is the most rewarding. The next day patient say, oh, I have improved. So that's not an end. After 1 month, when he stops the medicine, the symptoms again appears. Then what will you do? Obviously you will ask for an endoscopy, but you must have encountered in your clinical practice how many would agree for an endoscopy. So what the guideline says, I'll so only the flow charts. This is a functional dyspepsia. See, in the first it has been mentioned it is the H pylori test. You test the H pylori and treat it. You advise the dietary modification and the lifestyle modification, and then you give. See, if the heartburn is there, then give only rabeprazole or pantoprazole. Don't combine it with the prokinetic. So I would say domperidone, levosulpiride, etopride as the more abused drug. It should not be used unnecessarily. So give only PPI. If the patient has the postprandial fullness or an early satiety, there you should add some prokinetic agent. Then you follow the response, try to add antidepressant. If patient doesn't improve, yeah, but remember all things. Okay, first of all, you should think of an alarm features, like if the patient is losing weight, patient is having anorexia, patient is having anemia, patient is having diarrhea. These are the alarm symptoms which you should not forget. This is regarding the functional dyspepsia. A young patient, a young fellow comes to you without any alarm features with the heartburn, there you should advocate. So for an H pylori, what do you think? We all know regarding the stool test, we all know regarding the serology, but what the stool test is very cumbersome, and I think it lacks the sensitivity. And serology, you take a blood and you might be doing the IgM and IgG, but see, even if in India we do recurrent H pylori. So those who have a past H pylori infection, and if you check an antibody, this will come positive. So this will not the sure shot you will say, okay, you have an H. pylori. Then what we do actually? See, this is very simple test, easily available. I would say it hardly takes 15 minutes. First, we allow the patient to blow in an analyzer. Then we give the tablet tagged with this C13 urea. If the H. pylori is present in the stomach, it will produce the urease, and this CO2 will exhaled in the breath. So after an 15 minutes, the patient need to blow in a bag, and through this we can make out the patient is actually having an H. pylori or not. This is the practice in the Western world and nowadays in India also. And if you say it has the sensitivity is almost 95% and specificity is almost 100%. And the advantage of this test is even the patient has taken a treatment and you want to reevaluate whether the H. pylori has gone or not, this test is beneficial. No other test, because I already told that serology can detect the past infection, but this is not. So this is very useful, because nowadays if you give an antibiotic for the H. pylori, the antibiotic resistance is so much that it may not eradicate properly, or sometime in an India when the contaminated food comes, patient gets repeated H. pylori. So that's very important thing. This is also one of the important factor which we miss in our clinical practice. See, you all have encountered the patient with the flatulence, मतलब gas थई जाए से. And the second thing is कि those patient who takes the food and after immediate within 30 minutes to 1 hour, patient need to go to a toilet. See, these are the common complaints. So what will you do? Obviously, one of the common reason is the irritable bowel syndrome, diarrhea predominant. But I would say the one of the common reason for this sort of symptoms is the lactose intolerance, and which is highly, I would say, because from childhood we have been taught that oh, milk to pivanu, दूध तो बहुत nutrition होय, and our patient also will not accept if you say stop milk. But we have most of the clinical studies says that almost 40 to 60% of Asian population is intolerant to milk. See, I am not telling that જે ચાઇલ્ડહુડની અંદર મિલ્ક ઇન્ટોલરન્સ હોય, that is very different because that lacks an enzyme, but this is an acquired deficiency. So this is the milk intolerance that occurs in an adulthood, matlab in 20, 30, 40 or 5th decade of the life. So this is very important, and so we have to document this test. And there is, see, previously we were withdrawing the blood 5 times and checking this for lactose intolerance. But now it is so simple. Give the lactose to a patient. Patient need to wait for 2 hours. Every 15 minutes they need to blow in an analyzer, and with this we can make a chart, and if the hydrogen goes up in a chart, it indicates that the patient is lactose intolerant. So it definitely improves the management. It's not only the milk you should avoid, but those who are lactose intolerant, you should avoid the butter, cheese, or even I would say sometimes the curd and buttermilk. Even you can ask the patient to take lactose free formula, or even we have the lactase supplement also. Matlab those patients who wants to take a milk but they are lactose intolerant, and give lactase supplement, they will improve. So this is very important in clinical practice, but I would say highly underutilized. See, I'll not go much detail regarding the manometry, but see, we have encountered patient in our clinical practice. Some patient has the dysphagia, means they are not able to swallowing, or sometimes with the pain, sometimes the regurgitation. Then the patient has done an endoscopy, nothing is found. We stamp this patient as oh, this is psycho, matlab he has a psychiatric illness. But see, this is the test to detect the motility study. Like there are certain disorders of hypomotility or hypermotility of esophagus, achalasia. This is very simple test. We insert the catheter through nose, we give water swallows to patient, and through a graph we can make out whether patient is having any motility disorder or not. And this hardly takes 5 minutes, and with the diagnosis we give the treatment and improves the management. So esophageal is one thing, but anorectal manometry is very important because it is for constipation. See, we all encounter the patient of constipation. We try to give the various combinations of laxative, but patient doesn't improve. So see, there are various types of constipation, like slow transit constipation, or I would say pelvic floor dyssynergia. See, these are the important differentiation. If you know which type of constipation, you can target the therapy accordingly. And even I would say the biofeedback constipation, where what we do, we insert the catheter in the rectum and there will be a screen in front of the patient, and we show the patient ki see the graph, matlab how you need to contract your bowel and how you need to relax your anal canal. So that way it is a somewhat of an exercise which can definitely help your patient to get rid of constipation. So 24-hour pH metry, this is the one of the test to document GERD. See when to use this test actually. See, sometimes you feel the patient is having GERD, hiatus hernia, you refer to a surgeon, surgeon operates it, do a fundoplication. But then what happened after a few months, the patient comes back to you, कि surgery પછી પણ ફાયદો ના થયો. So there this test work. In the Western world, this is mandatory test before referring the patient to any surgeon, because this will document the actual reflux. This is a simple test, matlab like the we do an Holter monitoring or 24-hour BP monitoring. A small catheter is being inserted in the nose. Keep this for, and one device will be on the abdomen. So this will measure the change in the pH in esophagus. So if the acid comes from the stomach to esophagus, it will be detected over 24 hours. And there is one composite score like Demester score. So if this is high, then definitely this patient is having the GERD and the surgery would be beneficial. So I would say at this point of time, we should not refer patient to surgery without doing this test. And this is very useful. And most of the patient, if having a document GERD, will improve with the surgery. Or even many endoscopic procedures are also available for the GERD. See, this is very important test for the liver disease. See, in your clinical practice, I think you might have seen many patients comes with an ultrasound report and which is telling a fatty liver. And patient have many questions कि what the fatty liver is it? And you tell कहीं ना था fatty liver तो बधाने होय छे. But see, that is not the thing. You should understand the fatty liver is one of the commonest cause of liver cirrhosis in India. See, I would say in Gujarat, it is even more than alcohol or even more than hepatitis B or C. The fatty liver can convert into a liver cirrhosis. So you need to identify your patient who can progress onto a cirrhosis. So previous days we were doing the biopsies, like insert a needle, but it is a painful procedure and it do have a complication. Well, this is a simple test. It takes hardly 1 minute. What we do, there is a shear wave which is passing by this instrument to a liver. It will give a total map of a liver. So two things we will know: the fat content of the liver, and the second thing, the amount of fibrosis, whether it is F1, F2, F3 or F4. So this red line is all bad cirrhosis. This green line is normal. And in between you can see the amount of fibrosis. And you can follow this serially. Matlab patient is having an F1 and if it is going to F2 and F3, then obviously this patient will develop cirrhosis over a time. So nowadays, obviously you will advise lifestyle modification. That is very, very important. But other thing, there are various drugs nowadays. For the fatty liver, there is saroglitazar. It can reverses the fatty liver. For the fibrosis, there is obeticholic acid, which can reverse this fibrosis. And there are plenty of drugs. So you can identify your patient and you should target a certain therapy to this group of patient, and which can improve the outcome, or we can definitely prevent the progression to a cirrhosis. So this is an endoscopic ultrasound. We all know regarding an abdominal ultrasound, through which we can see the structure inside like liver and pancreas. So this is the ultrasound which we do by inside. So see, pancreas and liver and biliary tree are surrounding the stomach. Whenever there is a gas, you cannot see those organs clearly. So transabdominal ultrasound will not image the CBD properly or a pancreas properly. So this is test to image those things. I would say it is more sensitive than an MRI to detect a small stone in the CBD who presents with a biliary type of pain. This is not only for the diagnosis, but you can take a biopsy. See, to taking a biopsy from a pancreas cancer or liver lesion or the CBD from an transabdominal, matlab most of the time you ask ultrasound person or CT person कि અહીંયાથી છેક જવાનું liver ની અંદર ને through and through, it is difficult. So this is for the taking a biopsy of those area which is not reachable percutaneously. And I would say even pseudocyst, pancreatic pseudocyst, nowadays in last 5 years, I have never referred to a surgeon. We can beautifully done by an endoscopy, and it is so easy procedure, patient discharge on a same day. even failed ERCP. So you have encountered your patient surgeon or a gastro could not cannulate the CBD, where we can take an assistant of an US. So in last 5 years, I haven't referred any patient with a failed ERCP. Matlab, you can approach any CBD by the US mean and you can complete the procedure. So that's an advantage of this instrument. Even gastrojejunostomy, see, it's being done by surgeon, but obviously stomach and jejunum, we can visualize the jejunum from the stomach, we can pass, we can put a stone and produce the do a gastrojejunostomy. So these are the future actually, which can replace the surgery and you can avoid major surgery to your patients. See, advanced endoscopy, I have already told you were taking the photos in your Nokia phone like VGA camera, and now you have the almost 30, 50 megapixel camera, and you can see the images, the difference in the images. Because see, so the quality matters. Matlab, it is not like that someone has done an endoscopy and it is proper. You have to visualize it properly. So what's an advantage of high quality images where you can identify those early lesions? And why identification of early lesions are important is because of this. You can obviously resect endoscopically. See, nowadays the endoscopy is so much advanced. See, you can see this is a large colonic tumor which we have resected, and you can see a beautiful the healing areas in this. So early lesions can be removed by endoscopy or colonoscopy without offering any surgery. So in the next video, I will show regarding the esophageal cancer that was resected by an endoscopy without any scar. Because till now we know regarding till now we know cancer is a surgeon's, matlab we need to refer, and esophagus cancer matlab you need to go through an abdomen or through a ear and you need to resect. See, you can see these are the areas of a cancer in the esophagus. See, we have marked those areas. This is the cancer of an esophagus. Biopsy was showing a squamous cell carcinoma. See, we have done a marking in this. Then what we'll do, we inject and we try to cut those areas. So if the lesion is early, matlab, see, the esophagus has 5 layers. If the lesion or cancer is limited to a first or second layer, which can easily be removed by an endoscopy without any incision. So you can see we are injecting, we are cutting those lesions through this knife, which is passed through the mouth endoscopically, and we resect out all the lesions, matlab completely circumferential, and you can see this is the lesion we have removed and pushed into the stomach. And then we remove, see, this is the mass lesion and this is the after resection. See, you can see beautiful picture of this. Okay, we have resected the lesion, and to prevent the stricture we have placed these clips so it will not perforate. So after the healing, I will show the picture. See, this is after 1 month of the lesion. You can see how this lesion has healed completely. So whenever the cancer comes to a patient, obviously it is very painful to accept whether he will go for cancer, chemotherapy, radiation, surgery. But if we identify this lesion at an early stage, it definitely makes a difference. So in the next 2-3 slides, I will conclude. This is regarding, see, Achalasia cardia, where the lower esophagus is tight and the muscle layer is tight. Nowadays, the standard of care is surgery. But what we can do here, it's a tunnel therapy. It's a future of endoscopy, I would say. See, esophagus has 5 layers. From here, we cut the first layer. From this, between 2 layers, we form the tunnel like this. So between 2 layers of wall of the esophagus, we pass our endoscope and then we cut the muscle layer. So why we are not cutting through and through this? Because it will cause the perforation. But here what happened? We cut this layer here and this layer here, and then we close the defect. So by this means people have removed the even gallbladder and appendix through a mouth, through an endoscope. So definitely this will come in future and people are doing. So this is, achalasia is a standard of practice now. In last 4-5 years, I have not referred this type of patient to surgeon, and we can easily remove by an endoscopy and patient can be discharged on the same day. This is the last slide regarding the capsule endoscopy. We all know endoscopy and colonoscopy. Capsule endoscopy is where we use for the small bowel evaluation, which is not reachable by an endoscopy mean. So patient is losing blood, having an anemia, we don't know regarding what to do. This is very simple test. You ask the patient to swallow a capsule. There is a gadget tied on the abdomen which takes the recording till the capsule reaches to the colon. So it takes almost 50,000 to 60,000 images of your gut. So and then through a computer software, you analyze those pictures and can diagnose various disorders. So this is my team. We have a gastroenterologist and surgeon. So it is not like that every cancer come to us, I'll do endoscopically. We have the comprehensive team. So obviously we have to believe in teamwork. Some patient requires surgery, some patient requires the medical management, some requires the endoscopy, and it's a team. We take the decision according to the patient which is best suited. Thank you everyone for your time. Thank you.
Thank you very much, Dr. Sandip Shah, for the nice informative lecture.